Hello everyone, welcome to MycoClinics, the 4th of September 2025 edition, in which we'll be talking about fungal infections in solid organ transplant patients. We're very excited to welcome you to this edition, in which we have a clinical expert presenting a case with diagnostic considerations and processes, treatment deliberations, and also follow-up and outcomes. And this case will conclude with a discussion and literature review. People are very welcome to submit questions through the Q&A, which will be seen by the moderators. Myself, Nilesh Govender, I'm a professor at Wits University in Johannesburg, and I'm co-moderating the session with Professor Delia Warris, who's based in Exeter and is a pediatric infectious diseases specialist. So this recording will be available on the MRC CMM YouTube channel afterwards. And just to say that we organize these MycoClinics meetings every quarter in collaboration with a large committee listed on the slide. So I'm delighted to introduce Dr. Dionysios Neofytos, who will be presenting today, talking about PCP in solid organ transplant recipients. Dionysios is an attending physician at the Division of Infectious Diseases Transplant Infectious Disease Service at the University Hospital of Geneva in Switzerland. He completed his training in infectious diseases and internal medicine at the Thomas Jefferson University in Philadelphia, where he also completed an MSc in public health. He later joined the Transplant ID Service and the faculty of Johns Hopkins University and Memorial Sloan Kettering Cancer Center between 2008 and 2013. He's an active researcher in the field of viral and invasive fungal infections in immunocompromised people, and has published more than 150 peer-reviewed articles and books in the field. And just before we launch into the presentation, just for scientists and mycologists in the audience, to highlight the upcoming Myco talks, one on the 25th of September with presenters Angie Gilly and also Tua Wang, both from the US. And then on the 23rd of October, Bernd Schnabel and Michelle Olszewski, again, both from the US. And then also to highlight the medical mycology postgraduate certificate, diploma, and MSc offered through the MRC CMM at the University of Exeter, an online program targeted at clinicians and laboratory professionals who want to enhance their knowledge and skills in medical mycology. And this is a distance learning course and is really very, very valuable. So I'd encourage attendees to please look at the MRC CMM website and find out more about the medical mycology program. But now I'm going to hand over to Dionysios for his presentation. Thanks so much. I'll stop sharing.
Thank you very much, Nilesh. Thank you, Adelia, for the presentation, for the nice invitation. Hold on, I'm just trying to share my screen. I hope you can see my screen now.
All good.
Okay. So welcome, everybody. I will have to start by apologizing for two things. One is that I'm recovering from a viral infection, and I may have problems with my voice, so bear with me. And the second is that my office is on the side of the emergency department of our hospital, so we may have some background noise. For both, I apologize, but I'll try to compensate with with the case that I'm going to present to you. So as it has already been mentioned, I'm mainly taking care of immunocompromised hosts, including organ and bone marrow transplant recipients, and I have a particular interest in fungal infections, hence this presentation today, focusing on PCP in organ transplant recipients. Here's my disclosures. And on these slides, I'm sharing with you some data from the Swiss transplant cohort that highlight the importance of the underlying disease of our patients. And all organ transplant recipients are different from hematology patients, different from bone marrow transplant recipients. We have to think first of the anatomy. There's thoracic and abdominal organ transplants, of the immunosuppression, particularly what kind of induction our patients have received, particularly when they have been induced with hemoglobin, whether they have had an episode of rejection recently, and what kind of treatment they have received. And therefore, all those variables will have an impact uh, on the susceptibility of our patients to different types of infections. And on the right side of this slide, I'm showing you some recent data from the Swiss transplant cohort, showing clearly that bacterial infections represent the major pathogen family that our patients get infected with, followed by viral, and fungal infections are not that frequent, but nevertheless they occur, and when they occur, they're usually infections due to candida, mold infections, and occasionally we see infections due to pneumocystis, which will monopolize our interest for the rest of this discussion. And when we look at the epidemiology of fungal infections, as I already mentioned, invasive candidiasis remains the most frequently identified complication in terms of fungal infections in this patient population, associated occasionally with mortality rates as high as 35%, particularly in liver and heart transplant recipients. Invasive aspergillosis follows with a 1-year incidence of 2.4%, varying from 1 to 8% based on the different type of transplants. And mortality of invasive aspergillosis has significantly improved for all organ types except for liver transplant recipients, which continue to have mortality rates at 12 weeks post-infection as high as 80%. Coming now down to PCP, the overall incidence post-transplant has been reported to be somewhere between 5 and 10. There's cohort studies reporting incidence rates as high as 15%. But if we look at the Swiss transplant cohort, we have found that the 1 year post-transplant cumulative incidence of PCP is in the range of 1.5%. 1 year mortality remains low, down to 15%, but nevertheless, it's an infection that has significant morbidity and is associated also with high mortality. Now, on this slide, I'm going to use this Swiss transplant cohort study, epidemiological study, to demonstrate a number of different things. And on the first top, on the left top, we see the overall incidence of PCP during the first 8 years post-transplant, and for different types of organs. On the left side, you can see that the highest incidence here is 5%. So we're talking about incidence rates between 1 and 4%, higher in patients with heart and kidney transplants, lower for liver and lung transplant recipients. And when we go to the right side of this figure, we see that the incidence was significantly higher in one of the Swiss transplant centers that reported cases for this cohort compared to all other centers together. And looking on the left lower side now, we can appreciate that for all transplant centers other than the center 2, the prophylaxis for PCP was in the range of 80 to 90% throughout the study period, with an incidence ranging between 1 and 2%. In contrast, for the center 2, the prophylaxis administration was below the average rate for all other centers, which was reflected by higher rates of PCP during the first part of the study period. And as soon as prophylactic rates increased, the incidence of PCP went down and probably matched the rest of the cohort. And this is also demonstrated in the last figure of this slide, where we can see the isolated increased incidence of PCP in one single center during the period that prophylaxis was not administered, compared to the other centers, and the same center after prophylaxis was intensified. And what does this study tell us? It tells us that essentially the administration of prophylaxis can prevent PCP quite efficiently. And when we look at the incidence of PCP after the first 6 months post-transplant, the first 3 months post-transplant, we can see that as soon as prophylaxis is discontinued, then PCP starts coming in. And in terms of duration of prophylaxis, what we reported in Switzerland was that in most organs, duration of prophylaxis is about 1 to 3 months. In contrast, for patients with heart and lung transplant recipients, prophylaxis may be as long as 1, 2, 4, 5, or even 10 years in some cases. And all that was for me to just introduce the concept of anti-pneumocystis prophylaxis, which has become quite standard of care and is administered throughout the world in all organ transplant recipients. There's consensus guidelines that suggest that prophylaxis should be continued for 6 to 12 months for all but lung transplant recipients. And for lung transplant recipients, that should be considered to be extended for as long as possible. Sometimes there are centers that practice lifelong prophylaxis for PCP. In our center, we give 3 months of PCP prophylaxis in kidney, pancreas transplant recipients. We give at least 1 year of prophylaxis in heart and lung transplant recipients. What can we use for prophylaxis? This is also quite standard. Trimethoprim sulfamethoxazole remains a preferred option. The dose, though, can vary. There are centers that use 1 single strength tablet of cotrimoxazole once daily. There are centers that use 1 double strength once daily. There's centers that use 1 double strength 3 times weekly. And there's also centers that use 1 single strength 3 times weekly. And the consensus, there's not really a consensus. I think that this depends on the institutional cuisine for different transplant centers. And it's true that we do not necessarily have good prospective randomized clinical control trials to guide us here. We have extrapolated most of our data from the HIV literature, not only for prophylaxis, but in general in PCP management. But the question remains out there: which of those doses is the best one? And we do not necessarily have an answer. Oftentimes, have we patients with a reported bacterium allergy, and in those cases, the recommendations are to either go with atovaquone once daily or to administer aerosolized pentamidine once monthly. This is not something that we do quite commonly in our center, but nevertheless, aerosolized pentamidine remains an effective and quite efficient way to prevent PCP. Is well tolerated by patients, and it prevents patients from getting 1 more pill once daily or 3 times a week. So with this introduction now, we'll go I'll go ahead and present my patient for today. which is a 58-year-old patient that was transplanted with a kidney and pancreas a couple of years ago. The patient was induced with immunoglobulin, received maintenance immunosuppression with prednisone, MMF, and tacrolimus, and received 3 months of valganciclovir prophylaxis for CMV and 6 months of cotrimoxazole double strength 3 times weekly post-transplant. We saw this patient about a year and a half after their transplant. It was in February of last year. The patient was on tacrolimus and everolimus as maintenance immunosuppression. And there was a complaint of about a month of dry cough prior to admission. Now, it was not clear whether this had started as a viral infection and it sort of lingered after the viral infection, but the patient did say that started out with some upper respiratory tract infection symptoms, and then there was this dry cough that persisted, and it was getting worse and worse, up to the point that 1 week before admission, the cough was so severe that the patient sometimes had to throw up post coughing. And it was at that point that they noted that there was a fever of about 38 to 38 and a half. And eventually that prompted an admission with vital signs on admission shown here, a fever of 58.6 and a saturation of 82% on room air. A chest CT was performed that showed bilateral ground glass opacities, as showed here on multiple cuts, bilateral pleural effusions, and some sort of dense diffuse consolidations, particularly in the left lower lobe. Based on this initial presentation, a non-invasive diagnostic workup was initiated, which came back negative for all usual suspects, including typical and atypical bacteria, respiratory viruses, and a serum galactomannan was performed that was also negative. The patient was treated empirically for community-acquired pneumonia, but since there was a clinical deterioration with persistent hypoxia, there was an ICU transfer, and at that point we initiated an empirical therapy for PCP with IV cotrimoxazole. We were waiting still for the results of the serum beta-glucan test, which was performed at the time only twice weekly in our hospital, and we also requested the pulmonary consult for a bronchoscopy. So did this patient have risk factors for PCP? And the answer is that not necessarily. There's a lot of work that's been done in terms of identifying risk factors for PCP. We do know that the lack of prophylaxis is definitely a risk factor, but when do people get PCP? It's usually during the first year post-transplant, or usually after a recent episode of rejection and intensification of immunosuppression, which this patient didn't really have. Nevertheless, the patient was still within the first 2 years post-transplant, so it's still a period that remains quite fragile, particularly in a patient who was induced with immunoglobulin. So we eventually got the results of the beta-glucan test, which is a turbimetry test using the WACO assay in our hospital, and that was positive at 121 picograms per ml with a cutoff of positivity at 7. So what do we know of beta-glucan and PCP? Actually, we know a lot of things, and it's one of the non-invasive biomarkers that has quite important clinical significance. We know that there are at least 5 different assays available. Most data and most guidelines use the Fungal test cutoff of 80 picograms per ml. As I said, in our institution, we use the WACO turbimetry test with a cutoff of 7. There's multiple caveats about the beta-glucan. As you all know, it's an antigen that's produced by almost all fungi, except for Mucorales and Cryptococcus, and therefore the positive beta-glucan does not necessarily give us a lot of information in terms of which pathogen we're dealing with. In addition, we can have false positive results, particularly in patients who receive IV immunoglobulins, particularly if we think of the pulmonary transplant or the bone marrow transplant recipients who have regular administration of IV immunoglobulins. We should always keep that in mind. In addition, most PCP data come from the HIV literature in terms of how to use beta-glucan, where we know that it has an excellent performance with a high negative predictive value of more than 90%. In contrast, the cutoff data that we have for positivity of this assay come mainly from hematology patients with invasive candidiasis. Therefore, it's not necessarily that straightforward to be able to interpret a positive result, but the clinical context can be of some help. Also, the patient population that we apply this test on can be quite helpful. We do know from retrospective studies that beta-glucan values may vary depending on patient category. They're lower in hematology patients, higher in solid organ transplant recipients. And we also know that higher cutoffs have been associated with improved test performance. And to address some of those points, I will use a study that I like a lot. Not because I worked with some of the investigators when I was at Memorial Sloan Kettering in New York, but because it's a study that provides us with valuable information in terms of this performance of beta-glucan in patients with PCP. What Sigal Morjaria and her group did in New York was a retrospective evaluation of more than 400 patients at Sloan Kettering during 2012 and 2015. And after reviewing the patients carefully, they identified 53 patients that had a positive PCR for pneumocystis and 385 patients with a negative pneumocystis PCR. Now, keep in mind that these patients were mainly patients, mainly immunocompromised, but also patients with hematology or solid tumors. When we look at the performance of the beta-glucan test with the cutoff of 80 between PCR positive and PCR negative pneumocystis patient, we can appreciate that the sensitivity is in the range of 70% with a negative predictive value of 95%. If we increase the cutoff from 80 to 200, we drop the sensitivity to 52%, and the negative predictive value remains still in the range of 90%. Therefore, what those two tables tell us is that in higher risk hematology and solid tumor patients, a positive beta-glucan above 80 can diagnose PCP, but a negative it has high enough negative predictive value to rule out a PCP. When those analyses were performed based on whether a patient had definitive or probable PCP versus possible PCP, we can see that with a cutoff of 80, the sensitivity was 87%, and a negative predictive value went down to 70%, but this time the positive predictive value was up to 94%. And when a cutoff of 200 was used, the sensitivity was about 70%, but the positive predictive value was as high as 100%. So whereas we can use a cutoff of 80 to rule out PCP with a negative predictive value of 95%, when we do have a positive beta-glucan above 200, our positive predictive value can be as high as 100%. So this study sort of gave us an interesting range to rule out and to rule in PCP. with the use of beta-glucan. In the meantime, the patient had a bronchoscopy performed. We had a BAL that had 93% macrophages, 5% lymphocytes. Fungal stains were negative, but the direct fluorescent antibody stain was positive for pneumocystis, and a pneumocystis PCR came also positive with a cycle threshold of 34. So based on those results, we go back to our definition guidelines as by the AORTC MSG group from 2019, and we can safely call this case a proven case of pneumocystis pneumonia. If our immunofluorescence staining was negative, this patient would qualify for a probable diagnosis based on the presence of host factor, of clinical factors, and also microbiological evidence based on the fact that there was a positive beta-glucan and a positive PCR test for pneumocystis. Now, what do we know about pneumocystis PCR and its diagnosis of PCP? I will refer to the next study, which was performed by one of my current colleagues here in Geneva when she was in Paris, and Bergeron group. And what they did with this study was to prospectively identify patients between 2002 and 2005. And the vast majority patients with a hematologic malignancy and a bone marrow transplant, but there were also 5% renal transplant recipients in this cohort. They took the respiratory specimens collected, either an induced sputum or BAL, and tested them with a conventional assay and also a pneumocystis PCR. Now, out of almost 400 patients, excuse me, reviewed, there were 39 patients with PCP based on conventional staining, with an incidence of about 8.7%. 34 out of 39 of those patients had a PCR that was positive. In 5 of those patients that PCR was negative, the patients had been treated for PCP for at least 2 days before the test was performed. Although that should not necessarily lead to a negative PCR test, it was identified as a potential cause of a negative PCR. In the meantime, they also found 32 patients that had negative conventional stain, but a positive PCR for pneumocystis. Out of those patients, only 21 had a follow-up that was available for more investigations, and 14 out of those 21 patients were eventually diagnosed with PCP and treated successfully. So based on those results, the authors concluded that the use of PCR in high-risk patients for the diagnosis of PCP had quite a good performance, with sensitivity and specificity ranging between 87 and 92%, and a negative predictive value of 99%, with a positive predictive value of 51%, for a prevalence of about 8.7%, as shown on the figure on this slide. Now, is a pneumocystis PCR result a qualitative or not? The answer is that we need more data to be able to better assess the PCR results for pneumocystis pneumonia. A lot of studies have been performed previously. The problem is that these studies have important heterogeneity regarding the type of population. For instance, there's a proportion of HIV and non-HIV patients, the type of sample. In some studies, there's only BAL, in some others, only induced sputum samples. Also, the PCR target may be different, with mitochondrial RNA used in some studies, with synthesized gene used in others. And also the quantification method can be also different, with some studies using copies per ml and in others cycle threshold. However, one of the most representative studies in assessing quantitative results of pneumocystis PCR for the diagnosis of PCP comes from the University of Lausanne, from here in Switzerland. And I would love to share those data with you because I think they're quite compelling and they can provide us with useful information in terms of how to interpret the positive pneumocystis PCR. In this study, 71 patients were reviewed. More than half of them had a hematologic malignancy. The study period was between 2009 and 2017. And it was a retrospective study in which all patients had a positive BAL pneumocystis PCR. Patients were then divided in 3 different groups. One group with a PCP diagnosis, either definitive, based on a positive immunofluorescent test, or probable, based on host factors, clinical presentation, and response to PCP treatment. There was a group of 12 patients with an indeterminate PCP diagnosis, and there were 15 patients that were considered to be colonized with pneumocystis. Now, when they looked at the quantification of PCR by those 3 different groups, it was evident that there was no difference between patients that were colonized and had an undetermined diagnosis, but patients with PCP had significantly higher titers of PCR for pneumocystis than the other 2 groups. And when we look at the table on the right side, with different cutoffs used, the best cutoff found to represent a cutoff which could discriminate PCP from colonization was a cutoff of 5,000 copies per ml with a sensitivity of 97% and positive and negative predictive value of 90 and 95% respectively. And this is consistent with a lot of other studies that have suggested that the cutoff of about 1,000 or 5,000 or 1,000 copies per ml may be significant enough to use to call PCP. So in this case, we had, as we already discussed, a diagnosis of proven PCP, and the patient was treated with IV cotrimoxazole for 3 weeks. And steroids were also administered based on the fact that the patient was severely hypoxic and using both current recommendations and extrapolating data from the HIV literature. And in the last couple of minutes, I will discuss treatment with anti-PCP treatment and the administration of steroids for PCP in non-HIV patients. So Jay Fishman has published this table in terms of what are the recommendations for the treatment of PCP. As for prophylaxis, trimethoprim sulfa remains the preferred agent, but of course with much higher doses, between 15 and 20 milligrams per kilogram per day. I have to admit that almost never have I used 20 milligrams per kilogram per day. Usually I do 15 mg per kg per day for patients with severe PCP. Now the question is, where does this recommendation come from? And is 20 better than 15 and is 15 better than 10? We do not necessarily know. And we don't necessarily know because there's really not good data. I particularly like this study that was recently published, and it's a study from Japan, where they took 136 non-HIV patients with PCP over a long period of time, from 2006 to 2021, in multiple centers in Japan, and they divided the patients in those that received low and those that received high dose trimethoprim sulfa for PCP, and the high dose was defined as 12.5 to 20 mg per kg, and anything below that was considered as a low dose. And when they looked at data such as 30-day and 180-day mortality, there was no significant difference between the 2 groups. In contrast, patients that received low-dose trimethoprim sulfa were less likely to have adverse events, particularly nausea and hyponatremia. And there was also a trend for less patients treatment interruption in the low, rather compared to the high-dose trimethoprim sulfa group. And this study sort of summarizes what we already knew from a meta-analysis that was published about 5 years ago now, that reported that, in fact, using lower doses of cotrimoxazole, and here low was defined as below 15 mg per kg, did not have any significant impact on survival. However, it was associated with lower rates of adverse events. So based on that, I believe that we do need better data to define the optimal dose for the treatment of PCP. But the current guidelines, as I already mentioned, suggest that a range from 15 to 20 mg per kg of trimethoprim component. Now, what about steroids? As I have already mentioned, steroid administration has been recommended, particularly for HIV-infected patients, based on survival benefit and mechanical ventilation avoidance that has been demonstrated in this specific patient population. Now, there's no definitive data on the benefit of steroids in PCP treatment in non-HIV patients, and particularly in organ transplant recipients. Nevertheless, based on our most recent guidelines, steroids have been recommended for the first 3 days of treatment in patients who present with hypoxic PCP. As you can see on the slide, the recommendation is strong, but it's based on low evidence. Now, this recommendation was made by Jay Fishman, who was the senior author of the study that I'm going to share with you, that investigated once again the question whether steroids can be or are of benefit in patients, in organ transplant recipients with PCP. And this was a multi-center cohort of about 200 patients with PCP, including 21 transplant centers from Canada, the United States, Europe, and Australia between 2015 and 2020. The diagnosis of PCP was based on radiologic findings and any of the following tests that you can see there. And you can appreciate that the cutoff of PCR was more than 1,000, as I have already alluded to. The question was whether corticosteroid administration at any time and during the first 72 hours of treatment is beneficial or not. Amongst those 172 patients included, the vast majority had received an abdominal transplant, and more than 80% of patients developed a late onset PCP after the first year post-transplant. Not everybody was treated with steroids, so 1/3 of patients had not received steroids for their PCP treatment. And when we look at the predefined outcomes, we see that the 90-day mortality following PCP was in the range of 20%, which is very close to what has been reported in literature, and the ICU admission rate was 43%. Now, did steroid have an impact on mortality or ICU admission? We see on this slide, which is quite busy with a very busy table that I'm going to try to make as simple. On the upper part of the table, we see the different variables, including administration of steroids at any time during treatment. And in the lower part, we see the effect of steroids administered during the first 72 hours post-admission. There's 3 outcomes: death, ICU admission, and composite outcome of death and ICU admission. And if we focus on steroids at any time, we see that there was no effect on mortality, no effect on the composite endpoint, and maybe a small trend for less ICU admission. But when we look at the administration of steroids during the first 3 days post-diagnosis, there was really no effect on any of the outcomes studied. So based on this study, the question remains whether we do need to give steroids in organ transplant recipients with PCP. And I think we need more data and better quality data to be able to answer this question. So with this, I'm going to conclude by reminding us all that PCP remains quite a frequent infection post-transplant, particularly after the first year post-transplant when we stop prophylaxis and our patients remain immunocompromised. High clinical suspicion remains a key factor to diagnose this infection, both clinically and based on what we see on imaging tests. We have made a lot of progress, and we do not necessarily need to do a bronchoscopy those days to be able to make the diagnosis, as we can use serum biomarker, beta-glucan, and we also have the availability of pneumocystis PCR, not only on BAL, but also on non-BAL specimens, something that I did not really address today because we don't necessarily have the data for organ transplant recipients. Treatment and prophylaxis guidelines remain relatively unchanged, with trimethoprim sulfa remaining the preferred agent for both prophylaxis and treatment. But we do have a number of questions that remain relatively unanswered. One, what is the optimal dose of trimethoprim sulfa for the treatment of pneumocystis pneumonia? And two, whether steroids are absolutely required for the management of high-risk patients. And with this, I will thank you for your attention, and I'm happy to take it to the next level and answer any questions and enjoy, hopefully, an interesting discussion. Thank you very much.
Thank you so much, Dionysios. I mean, that was a brilliant talk with really guiding us through the management decisions to be made when treating patients, and supported by lots of literature. Yeah, I learned a lot. Thanks for that. Please, everyone who is online, feel free to put your questions in the Q&A, and Nilesh and myself will pick them up or group them together to discuss with Dionysios. So I'm going to address the first question in the Q&A, which is asking about the patient you presented had pleural effusions. The comment is addressed to that is a rare observation or rarely seen in PCP. So that would have lowered in the differential diagnosis PCP on the list of kind of likelihood. So could you comment on your approach to a solid organ transplant patient with radiographic opacities consistent with PCP but with pleural effusions?
Yeah, that's definitely not a very common manifestation, I have to say. I agree. When we saw those pictures, that could definitely be volume overload, for instance, with this crown glass pattern and the bilateral pleural effusions. Nevertheless, when we go back to even the initial HIV literature, we can appreciate that PCP has multiple different patterns of presentation and imaging testing. It can present with a dense consolidation, it can present with a kyst, it can present with micronodules, it can occasionally present with pleural effusions. But I agree that it's not necessarily the most common presentation. That said, we should also keep in mind that organ transplant recipients, they're not the typical neutropenic hematology patient that will present with the typical radiological findings. We also know that in organ transplant recipients, invasive aspergillosis, for instance, may not necessarily present with a typical large nodule with a halo sign, and those patients may have also ground glass opacities, pleural effusions, consolidation, and they have a full-blown invasive aspergillosis. So yes, I agree, it's not the standard that someone would expect, but it should not necessarily deviate us from a diagnosis if the rest of the clinical picture is suggestive of PCP.
Okay, thanks. There is another question in the chat. In case of allergy to cotrimoxazole and desensitization fails, what is the best strategy in your view for prophylaxis?
For prophylaxis, I think it's easy. For me, it's either atovaquone or pentamidine aerosols. If it's not a heart transplant recipient with a positive toxoplasma serology, which is the patient population that I would still like to have an anti-toxoplasma activity, and therefore I would insist for atovaquone. In other cases, I may go directly to pentamidine for two reasons. One, because atovaquone is not always well tolerated. Patients tell you that it's just so hard for them to take this liquid every day. They just find it very inconvenient and very unpleasant. And two, because pentamidine we can administer once monthly, so it makes things much easier. I would not use dapsone because we do have data that suggests that dapsone remains the least effective PCP prophylaxis.
Yeah. Okay. Thanks. Nilesh, do you want to come in?
Yes, thanks, Dionysios. Great presentation. Thank you very much. I wanted to find out about your approach to patients who don't respond to treatment. When we manage patients with advanced HIV disease, there's a specific, series of thoughts we have when patients don't respond to treatment. And I'm just wondering what your approach is in the solid organ transplant recipient population. Thanks.
Yeah, as you said, the patients are a little bit different to compare, but not necessarily. Meaning, if you have an HIV patient who's on treatment with good CD4 count and good immunological response, then if that's a PCP and if you treat it correctly, then the patient should respond. So when does the patient not respond? One, when we have made the wrong diagnosis. Two, when their immune system is really failing. And three, when we're not giving the optimal therapy. And I will elaborate for the last two parts. So what do I mean by their immunity? So sometimes, and every time that we treat an opportunistic infection, at least in the organ transplant world, we say, let's try and decrease the intensity of immunosuppression. That may not always be possible, particularly if the patient has been recently treated for rejection, but sometimes we are able to decrease the dose of prednisone or even stop the MMF for a couple of weeks so that we can give the patient's immune status the opportunity to build up and help us contain the infection treated. The last point was when we treat a patient not with our best option. There was a question before about trimethoprim sulfa allergy. Oftentimes we have patients that are labeled or mislabeled as allergic to trimethoprim sulfa, and or patients who are fresh out of a kidney transplant, their renal function hasn't recovered, and the transplanters, they don't want to use IV Bactrim, and in those cases they ask, well, we have to give them something, and we always come up with something, and most times do we give cleaned up primaquine. However, the alternatives to Bactrim are not as good, as effective treatments for PCP. And most of my failures have been associated with patients that I did not start directly on trimethoprim sulfa, and eventually I was obliged to because they did not respond to the second or third line therapy.
Yeah. Okay, maybe that leads somehow into, do we have other treatment options? And there is a question about caspofungin. And maybe take that a little bit broader. This is a question, adding caspofungin in severe cases, but are echinocandins worth to be looked at as a treatment options in PCP? There is the preclinical data, you must be aware of that. Can you elaborate on that?
I can and I can't. Yeah, I can tell you that there is data that, to start with, in vitro activity of echinocandins is excellent against pneumocystis, particularly the second generation echinocandins, namely the resofungin, has quite good activity against pneumocystis. It has been proposed as second-line therapy. I think in severe cases of pneumocystis, I wouldn't. I would consider a combination therapy. I haven't used it personally. I know of people who have done it. I think I usually have a very low threshold using echinocandins because they're so well tolerated and they have minimal drug interactions. However, I have to say that I'm blacking out on any data as first-line monotherapy with echinocandin. That there may be, but I can't think of the top of my head.
I'm only aware of a phase 2 clinical trial which has just finished. They enrolled 25 patients into each arm. This is a trial enrolling adults with advanced HIV disease, and they were randomized to either receive cotrimoxazole and corticosteroids versus resofungin, as well as cotrimoxazole and corticosteroids. So, it's a small study, really not powered to look at efficacy, really looking at the safety. Day 8 clinical outcomes, I think, as the primary endpoint. Those are brand new data. I don't think they've been released as yet. So, definitely potential, but more RCTs are definitely needed, and certainly in the hematology setting and also in the solid organ transplant setting.
Yeah, it's true that I have to say that resofungin looks quite promising, particularly because of its lower MICs against pneumocystis, and also because of its very higher concentrations in the lung tissue. It tends to concentrate in the lung much better than the first generation echinocandins. I know that there's this very interesting clinical trial that is now ongoing at phase 3 as prophylaxis in bone marrow transplant recipients to replace prophylaxis, antifungal and PCP prophylaxis with one single administration of resofungin once weekly. And I think that would be quite interesting to look at the results of that trial. But for treatment, I have to say, I've never used an echinocandin.
Okay, thanks. I see a new question is popping up in the chat. What is the incidence of co-infections of PCP with CMV in transplant patients? Is that something you come across?
Mm-hmm. Yes and no. I don't know what the number is. It's definitely one of the risk factors that CMV can predispose patients to opportunistic infections such as Aspergillus or pneumocystis. Most data out there are for Aspergillus, particularly from the BMT literature. Those are also quite old data. CMV tends to be less of a problem today with our prophylactic approaches. So I can't give you a number, but it's definitely one of the well described risk factors.
Okay, thank you. Nilesh, any additional questions?
Just related to that, I think Trevor was also asking, based on the pleural effusion in the CT scan of your case, Dionysios, did you consider TB in the differential diagnosis?
We did. All patients get a quantiferon before the transplant in our center. That patient had a negative quantiferon. It was a patient who was local, hadn't traveled. Our prevalence of tuberculosis is quite low, so that was rapidly rolled out. But we also had a gene expert that immediately came back negative from the BAL. So our clinical suspicion was and remained low.
Thanks. And I guess one more thing, I'm sure it's an evidence-free zone, just in terms of monitoring response to treatment, biomarkers, that sort of thing. Do you have any thoughts on that?
That's a good point. Well, the poor man's biomarker CRP works quite fine in PCP cases. We see quite a fast drop in the CRP when the patients respond. However, when we talk about fungal biomarkers, particularly beta-glucan does have the tendency to persist at high rates and remain positive for a long time. So we do not necessarily recommend using the follow-up of beta-glucan for clinical response. It's not as with the galactomannan. We know that in a couple of weeks galactomannan should go down, should be negative, and that's how we can assess clinical response for aspergillosis. But for beta-glucan, the data are a little bit dubious there.
Thank you.
Thanks. And with that, I think we have to close this webinar. It's almost 5 o'clock. Thanks again, Dionysios, for a great talk and for a really great discussion. I want to thank the audience who have joined us this afternoon for this webinar. We hope to see you all back, or please do join us in December for our next MycoClinics. And for now, hope to see you back. Thank you.
Thank you again.
Thank you.